on microneedle radiofrequency because I use it for a couple of years with a huge success. And for my background, I'm a dermatologist and do aesthetics as well as medical. And this is a device that we can use in both medical and in aesthetics. So it's very useful, it has lots of indications, and I will show you later some pictures before and after. But also, let me start with a introduction to the topic, because maybe not every one of you is familiar with the basics of microneedling RF. That's one point. The second point is what makes the difference between this device and other devices that you might find in the market. So I think I should first just highlight the major basics and what makes the difference. So first of all, it's the type of RF. You might remember that RF can be different, like monopolar, unipolar, bipolar, or multipolar. Radio frequency, other than lasers, which are chromophore related, radio frequency is unspecific. They call it color blind. They create some heat in the tissue, and this follows the Ohm's law because the impedance to the movement of charged particles creates this heat, and this is depending on fluence and certain parameters. So we create some unspecific heat in the tissue, and by some technological details we can determine how deep we are going into the tissue. And this is different from the radio frequency that we might have used 30, 40, or even 50 years ago, that we used to coagulate and to cut. Now we have cooling, we have microneeds, etc. That brings more indications in different applications. So that's the basic. Now, unipolar, bipolar, or even others, what is the difference? Unipolar uses a single electrode, like the thermage, and the energy is delivered at the boundaries of the electrode, so always cooling is required. The bipolar is only between two poles. There's an electrical current, but the penetration depth is half the distance between the poles, so it's very superficial, but it's very safe. And if you have many of these bipolar, then you can call it multipolar, as you see in these graphics. So that unipolar, single electrode, and bipolar, two electrodes with limited penetration depth. You can deliver with a microneedling device actually both. You can do monopolar as well as bipolar, depends on what radio frequency you bring through the needles. Now, what's the difference to lasers? If you see the laser, you know the ablative laser I mean, then we do an ablation superficially. However, this creates, through vaporization, some damage to the superficial layers. Only if we damage, we can penetrate deeper and get the necrosis and coagulation and surrounding a protein denaturation. This is actually what we want to get for a tightening effect or for collagen neogenesis. With the FRM, the radiofrequency microneedling, we first deliver the needle into the tissue, and around the needle we create a very small edge of, say maybe vaporization, but then coagulation and a little bit of necrosis, but smaller, and we get the protein denaturation around this. However, we never damage the barrier, so this means we do not create really severe wounds, and we do not have any downtime. This is very important because your patient, when they get up after the treatment, you put on a little bit of a disinfection and cooling, and then they can go on without any really risk. You see that in the histology here. This is the ablation of an ablative laser, and this is when you can get same coagulation, but just in the depth where you want to go, and or you can determine it could be more superficial or more deep, but you have no damage, not such a wound as you have with ablative lasers. There are also other procedures that go on in the tissue as an impact of such a treatment, like there's a marked induction of tropoelastin, fibrillin, as well as procollagen, post these treatments, all markers that show that some new collagen production is taking place. This results finally, after a certain period of time, takes time, 3-4 months, some more dermal collagen, new elastin production, reticular dermal volume finally, and some more production of hyaluronic acid, elastin, and that brings the result clinically in improvement in facial tone and volume. Next basics that we should know are the needles itself, the microneedles. So what counts is the length. What kind of length, what kind of penetration depth do we have in a device, and does it offer? Are they coated, protected, and only the tip delivers radio frequency, or are they uncoated? And the way of penetration, is it smooth, or is it, and how long is it, and the number of shots finally. So what does that mean? These parameters, needle depth, the power that you deliver, and the pulse width, the duration of the pulse, are essential for the effect in the tissue. You see from histology here, this is a penetration of 1.5 millimeter. We can go as high as 0.3, but we can also go deeper, like 3.5, and in this device even 4 millimeter. And depending on what you want to achieve in the tissue, you can choose if you go superficially or medium deep or deep, like for instance tightening of dermal tissue needs deep, or some scars need medium deep, or some just refreshing of the skin or restoration of the basal membrane just needs superficial penetration. And what I usually do is, to get a better effect and not to over-treat, I do a 2-layer treatment, like for instance 3.5 and 1.5. So we have a much higher result. So that's the needle length. And if we want to go just superficially, like large pores, we can use the very superficial penetration of 0.3. But if we want to do these scar or fibrotic tissue perforation, we need the delivery of microneedling RF directly to the deeper layers in the dermis in order to achieve some objective deep regeneration for rejuvenation of those scars. Again, you see these superficial penetration, like superficial wrinkles, or here that's 0.5, and that's 1.5 to 2 millimeters, or you do even a combination of those. So you have to think about what you want to treat, what indication it is, and where you are localize the process that you want to initiate for new tightening or for refreshing, and that is your decision how deep you want to go in microneedling. Again, shows superficial penetration. Just if you use a 0.3, then you might be here, maybe you break a little bit the barrier, but usually you go deep without breaking the barrier superficially. Now, which indications, in summary, for which needle lengths? 0.3, very superficial, large pores, early wrinkles, aging prevention, sun damages, smoothing of the skin. You can even use it for drug delivery, by the way, if you use approved drug that you would like to apply and to put into the skin, for instance hyaluronic acid. You can do a subtle perforation of the skin and then apply this. 0.5, for instance, if you need a little bit or would like to achieve a little bit more rejuvenation, the first kind of tightening of acne scars superficially, medium-sized pores, same for 0.8. 1.5 is kind of a standard penetration depth for light scars. At 2 millimeters and above, we have 3.5, we have 4 millimeters, are for more deeper process like scars, lifting, tightening, etc. Maybe I go back to show you one point which matters, because whatever you choose, your penetration depth is always 0.1 to 0.2 millimeter less than your actual needle length, because you have to push it into the skin. So you have to stretch the skin, push on the skin, and then you deliver the needle. Still there is 0.1 to 0.2 less than the actual length of the needle. And the second point that you should know is the RF irradiation ranges up, down, and around the needle of 0.3 millimeters. So it's not very much, it's very localized, but it covers a certain area. So you see that very nicely here in the histology. So if you put in the needle here, or here, or here, these are the 0.3 millimeter around your needle. If you put, or if you choose a long duration, like continuous wave, or high fluence, then you definitely get more coagulation effect in the tissue. So it depends on these parameters as well. And here we have something that you should also be aware of, because our skin does not often show the same thickness in all locations. The very thin ones are the lower lip, or the tip of the nose, or the neck. Neck is a really risky area, especially for ablative lasers. You can easily create hypertrophic scars. What does not happen with the microneedling RF? Eyelids are very thin. Others, like forehead, for instance, or upper lip, are much thicker. So according also to location, not just to indication, you can decide which kind of a penetration you would like to have. Second point for needles, coated or uncoated. What is the difference? It started with the insulated needles, so coated, so that means they do not deliver any radio frequency around the needles until there to the tip, just at the tip. This was very specific, looked very safe, still is safe, and we have the heating there only. However, we have vessels here, and we do not coagulate these vessels, so we get more of this bruising during the treatment. But if we use uninsulated needles, then we deliver the radio frequency all along the needle and at the tip and a little bit around. Which means if they touch the superficial vessels, they do not just break and open them so that some bruising appears, but they also coagulate them, and we get much less of this bruising. The second is we get a more intense effect because we do this coagulation plus modulation result in a larger area. However, since this is just 0.3 millimeters around, we don't do it as aggressively as we would do it with a CO2 ablative laser. So it is still very safe. And there's one point, impedance of the tissue keeps the epidermis on the safe side, because we cannot heat up the epidermis in this as much as we then coagulate the dermis. So no coagulation along the needle means more bleeding points, and coagulation all along the needle creates more coagulation and needs less sessions. That is summarized here. So we need more sessions with the coated needles than with the uncoated. Now, the other parameters that we have to check, and you have to check if you buy a device, what kind of variability do you have? These are the pulse duration, and this is really specifically unique. You will hear more about that with other presentations later. The fluence and the question, continuous or pulsed delivery. What does that mean? Now, first of all, let's go to the continuous delivery. Here we have intensity and exposure time. Intensity is the fluence and exposure time. Here we have a two-layer treatment. This is a superficial let's say 0.5, and this is 3.5. And intensity is 5 watt. Here intensity is 50 watt, but exposure is 80 milliseconds. Here is also 80 milliseconds. What makes the difference? If we increase the intensity at the same time for exposure, you see that we get a larger coagulation and a more intensive reaction. But what happens if we keep the intensity, the fluence, same, like here on this side, intensity is 10 watt in both, but the exposure time differs. The duration of the delivery of this radio frequency heat. Here it's 100 milliseconds, there's 800 milliseconds. Again, you see, the longer we deliver, the more reaction we get in the tissue. This is more superficial. In order to make it, to show it, it's much less. So if you reduce the exposure time and you reduce the intensity, you get a more subtle treatment, but you can increase both. And what I usually do is a deeper, high intensity, longer exposure, and a superficial layer, which is less intensive or less duration. You can do that also in an opposite way. Instead of increasing to 800 from 80, you can go maybe to 8 milliseconds and deliver that in a pulsed way. Then you have a very little coagulation, however, still you have an effect to the tissue. The result of this is, for instance, you do a 2-layer treatment and you get a coagulation in 2 of these layers, then this will result with a continuous wave, with a longer delivery and high intensity in the 3-dimensional shrinkage, much like the CO2 lasers. However, I repeat, it's not with breaking the barrier, the skin barrier, the superficial epidermal layers, and it has not the downtime because we do not create any wounds. And the clinical result is remodeling results with flattening of wrinkles and scars and tightening of skin laxity. Now, what is really new in this specific device that we are talking about, the Sylfirm X, is the new pulsed wave to deliver radiofrequency microneedling. And that this pulsed wave is important to treat vessels and also pigmentation. So we have, instead of the continuous wave, which is longer, that can be done in several pulses, we have very, many small mini pulses, just 30 milliseconds and 4 in a series, which does not heat up very much the tissue. So you do not really have a big coagulation effect. However, you have a puncturing effect on the vessels. This shows the continuous wave options that we have in the device, and this shows the pulse wave options. The continuous waves, that's what I just explained, to deliver a longer pulse, still can be divided into or differentiated into various durations. The longer you do, the more intense will be the effect. That means the longer ones are good for body tightening, for lifting, for skin type 1 to 6 stretch marks, scars, deep acne scars, even double chin you can do for that, or I will show you can also use it for hyperhidrosis. If you go to, let's say, CW2, then it's more the superficial effect, like face tightening and lifting, or even more superficial circulation. If you go to this pulsed wave, then we have also various durations. Starts with PW1, just a very short pulse, but 4 in a row. That increases with 2 and 3 to 4. So the pulses are longer, but they never are as long as with a continuous wave. This means no coagulation of the tissue with a tightening effect, but some coagulation of the vessels. And this procedure is now verified by a couple of publications. What are the indications for that? They are medical and aesthetic. Let's start with the medical indications. Among them are acne scars, vessels, rosacea, hyperhidrosis. You will ask, what do I need as a pre-treatment? Do I need any general anesthesia or topical anesthesia? I think topical anesthesia plus Zimmer air cooling, for instance, is completely sufficient. There are some options that we sometimes use or differentiate, like anesthesia with the topical amla cream or similar, or an ointment that is prepared in a pharmacy with 40% lidocaine, or we do with this device without radiofrequency or very low radiofrequency, 0.3, maybe 0.5, but 0.3 is so superficial that the patient has no pain with it. You do a very subtle pre-treatment with a 0.3 just in order to slightly perforate the stratum corneum, the superficial layer, and then you apply the topical anesthesia, which is nothing else than drug delivery, because then you bring the active ingredient very fast to the layer where you want it to be active. It is faster, it is more intense. That saves time for you and for the patient, and you get better results. Or I learned from a colleague, she does a very subtle chemical peel, which in the end is something similar, because if you do a subtle peeling of the stratum corneum, you also increase the delivery of the active ingredients to the deeper layers, which works much faster. And then she poured a syringe of lidocaine on this. And finally, if this is not sufficient, I use the cannulas that you use for PRP or for mesotherapy, just very, very tiny small droplets with a 32 gauge needle to deliver a kind of a injections of lidocaine. But really important is to use the air cooling together with this. If you use a topical anesthesia plus air cooling, you're always doing fine. And these are some indications. If you're interested in parameters, they're written here. Now this is continuous wave because there was acne scars a little bit deeper, so it needed a more tightening effect. If it gets better and more tightened and you still have some redness, then you can go to the pulsed wave because you don't need the deeper effects of the acne scars. And in terms of microneedling length or depth, I would use the 0.5 or 2 millimeter in this case. That's the lady that I treated for years. She, even at the age of 62, still suffered from continuous inflammatory acne, and which always resulted in new superficial scars, together now, however, with wrinkles. And we did continuous treatment, and that was very nice for her because she didn't feel very much of uncomfortable and pain, so she got improvement for both after 6 treatments. This was a young guy with a scar after an accident that we treated 6 times, and you see that was a real tremendous result, flattening of these hypertrophic scars with perforation and increase of vascularization with 6. And that was a young girl with artificial scratching scars that she did on her lower arm. So we did the 6 sessions, and I just lately saw her. There is nothing you can see anymore. So perfect. Maybe not a keloid, but these are not keloids. These are just hypertrophic and a little bit whitening, whitish scars, artificial scars. Again, acne scars. Here you could maybe start with a superficial one, then go deeper, or you do even a 3-layer treatment, deep for tightening, plus another layer for superficial reduction of the redness that we have here. Again, indication acne scars, 2 and 3, 0.3, and for both indications, for tightening and for redness. How about vessels in general? For instance, rosacea. Here we can use the pulse wave as well. As I mentioned already, the longer the pulses, the more intense the indication. So if you have inflammatory acne, you go better to the longer pulses or even to continuous wave 1 or 2. And if you have borderline stains, you definitely need the longer pulses. But if it's less intense, like these normal vascular lesions, you're doing fine with a pulse wave 3. This is not too long and is not so much coagulating. And only for the deeper ones you use the longer. And rosacea is a good example. Rosacea can be inflammatory. If it is inflammatory, you need the longer pulses, like continuous wave. And here you see also the depth, that's 0.8 to 1.5. Then, if it comes to redness only, inflammation is gone, you can do mild or severe redness, or even with telangiectasia or big size telangiectasia. You see, according to this, you can decide if you go very superficial with a PW2, the pulse 2, or even 3, and the more intense it gets, the longer you do the pulses. So this is what the device offers you. And these are some studies showing patients up to 4 weeks after 6 sessions of rosacea and telangiectasia. They did it in 2-week intervals, and it used 1.5 millimeter needles with 2 to 3 passes. You always have to press gently on the skin, your tip, to get the result. The same you see here is a little bit more intense telangiectasia. They had needed 12 sessions at 2-week intervals, used a higher power level of 3, did 2 to 3 passes with 1.5, and got the result. Another indication in future, I think, can be something that has been published with other devices that do not offer a needle length like this one. They only have 3.0 millimeter penetration depth. That's the hyperhidrosis. You might know the microwave technology to treat the sweat glands, to coagulate the sweat glands for a long-term effect. However, you can do that with microneedling as well. So far, the studies were only done with 3, maximum 3.5. Here we have 4 millimeters that we can use, and we need these 4 millimeters because the sweat glands are as deep. Otherwise, we are too superficial and we get only no result or limited result. Still, they got some nice results with even 2 passes in most of the patients. So many reports are like 50% reduction after 1 to 2 and 80 to 90% reduction after 2 treatments. These are 1 or 2 studies that I just want to mention. The hyperhidrosis disease severity was reduced, measured by telometer, and even skin biopsies have proven if you use 2.5 to 3 millimeters, we will get much better result with a 4 millimeter. And same here, you see the significant reduction, or also the iodine staining tests. So side effects were minimal, also discomforts, and histologically the decrease of these glands was shown. Other indications, aesthetics, starting with stretch marks, which is between aesthetic and medical, wrinkles, rejuvenation, last pores, laxity, and finally melasma and pigmentation. I just go through quickly some pictures of my own patients, like these stretch marks that can be improved. That was a level 1.5, higher level of intensity, 3 sessions. Then superficial wrinkles on the face, that's doing fine with a 2-layer treatment, 1.5 and 0.8, for instance. Upper lip wrinkles, for instance, or very nicely around the eye and eyelids. You can do a little bit of botulinum toxin in order to inactivate the muscles there, but then still you have the lines that have to be smoothened. And you use, for instance, here you use the 0.8, and on the lower lid you might use the 0.0 with a CW1 or 2, not too intense, but just a subtle stimulation. That's done with the Altera device that shows the superficial contour, and you see that 2 months later, always takes 2 to 4 months to see these results. You can see the smoothing out of these wrinkles. This is something for the 0.3 millimeter. Very superficially, it's an early stage treatment for the wrinkles, for the skin rejuvenation, and also for the prevention. That's a patient of mine who liked to go to the sun and got larger pores, got these early wrinkles. Décolleté area, also something not so easy to treat. There was 3 sessions with 1.5 millimeters and 3 sessions with 0.3, continuous wave. Tightening of this indication, I will not promise you that you can achieve a result which is really great for that indication. Actually, that needs surgery. But you can, at least if your patient does not want to have surgery, you can try with a 4 millimeter and continuous wave and several sessions to get some improvement, tightening in this area. New indications, melasma and pigmentation. We know that the pigmentation can be in different layers, and you have to be aware which layer you are targeting. Is it epidermal, like lentiginous, epiphytes, or is it dermal, like the otoiotonevi or even melasma? Or is it mixed, like PIH or melasma? And we know melasma can be epidermal, dermal, or mixed, or even indeterminate. Depending on that, we have to decide which needle length we use. And what we know from lasers is, if you take, for instance, 577 or 585 as a wavelength, they have an absorption in melanin and in blood, so that we have competing chromophores. We hit both in some way when we blow this or shoot this into the skin. So we get some epidermal pigment that we hit, and also some epidermal microvessels. And this was a benefit to the indication melasma, because we now know that with melasma comes an increased vascularity in histology in melasma, and there are some interactions between this vasculature and the melanocytes, so they play some important role in the reason why melasma is appearing. There are some factors that can be measured, like this one, and they are significantly show an increase in vessel size in melasma, in vessel density, and then compared to the non-melasma area. So that means if we treat the vessels in addition to the pigmentation, then we will get a better result. And this is the idea of using the microneedling with a pulsed wave, which does not coagulate, which does not stimulate the hyperpigmentation again, in order to reduce the vascularization below the melasma. There are some other publications, like elevated levels of cytokines that can affect the vascularization, angiogenetic factors, etc. I don't want to mention all of these biological details, but these are publications that prove that vascularization plays a role and can be decreased if you treat the vessels below the melasma. Same happens when you use vascular lasers, as mentioned. Always treat melanin and vessels, because we have the pigmentation and below we have the vessels. And if you shoot it in, you hit both melanin and vessels, and that's exactly what we do. But in this case, we do not have this chromophore related. And the studies on melasma with lasers have shown the same positive results. But with the pulsed microneedle RF, we can determine if we just want to restore the basement membrane, which is important. I think we will hear about that, but I think some minutes later on that. Or the epidermal melasma needs just a smaller penetration of the needles, dermal melasma or PIH. But for all of these, do not use the continuous wave, use the pulsed wave, which is more safe. Some publications like this melasma, they did 1.5 millimeter level 3 on the face, 1 millimeter depth on the forehead. On the rest of the face, they use 1.5, 5 to 10 treatment sessions. So if you are doing soft treatment, you need more sessions in order to be successful in 2 to 3 week intervals, and they got nice results. These 5 female patients, 4 to 7 treatments, and 1.2 to 1.7 millimeter needle, one single pass, achieved 50% result. That was one of our patients after 3 treatments with the Sylfirm X base, same here. Textural improvement in addition to melasma reduction. This was a split phase study on using microneedle radiofrequency and Q-switched Nd:YAG in a low dose toning, and you see that was the combined approach. So that disappeared more or less completely. Here we had a little bit of the rest that was Nd:YAG laser only. Again, melasma improvement in more than 140 patients and high patient satisfaction. They decreased also the senescent cells that we find in melasma more frequently than in the surrounding areas. These are the parameters. Here they used 0.3 millimeter penetration depth only to do a superficial epidermal melasma treatment. In this case, all 3. So this is what you can achieve, and I think we hear about that more with one of the following presentations. So in summary, the pigmentation, especially melasma, can be regarded as vascular dependent. And vascularization can be targeted together with the pigmentation, now with lasers, but also with non-laser technology, like this one. It has to be pulsed. It cannot be continuous, because then you worsen it definitely. But if you use this very new technology of a pulse type, bipolar, alternating current radio frequency, then you can get an improvement for both. So to conclude, I can give you a recommendation for reading on radio frequency and energy-based devices. That's a book or 2 books that I happen to do the chapter on the radio frequency by Springer and the other by Karger. This is a conference that some of you might have attended. Lim has attended this year and will be next year, middle of June in Portugal, an aesthetic meeting, the 5-Continent Congress. I would love to see you there and invite you to come. And for that, I thank you for your time. Thank you.
Thanks, Dr. Fritz, for the inspirational speech.